Tony Chepkwony. I support the National Cancer Control Program, specifically the second pillar that deals with cancer imaging, pathology, and lab medicine. So, as has been highlighted by Nelson, this is the first webinar meant to really commemorate the Cervical Cancer Awareness Month. I remember that this is something that we normally do every year. So being the Cervical Cancer Awareness Month, and we have 3 speakers for this session, and we believe that we have the prerequisite expertise, looking all the way from the policy level, looking at even scientific and clinical practice and research. So that is in matters cervical cancer, and we want to ensure that we really get to create awareness and even much of advocacy in matters cervical cancer programs. So I will be moderating this session, and we will, after the 3 sessions, I want to encourage us to really be asking questions using our chat box. So at the end of the 3 presentations, we'll have a Q&A session where we'll be able to respond to the various questions that will come from the participants. So once again, welcome to this session. And I won't take much time. I want to introduce the first speaker for the session. So that will be Dr. Valerian Mwenda. And Dr. Valerian Mwenda is a medical doctor and also an epidemiologist, currently serving as a senior technical advisor at Health Systems Insights. So Dr. Mwenda graduated from the University of Nairobi Medical School in Kenya, and he was able to complete his PhD in health sciences at the University of Ghent in Belgium. So Dr. Mwenda's research and professional interests include health policy research, exploring research evidence, incorporated into health policies, and how to use policies in terms of dissemination and implementation, evaluated, as well as the role of health economic modeling, and what this can really do to ensure that we play in driving policy advocacy. So Dr. Mwenda will be taking us through an aspect of HPV vaccines, looking at immunology, and even some aspects of vaccine safety and efficacy. So welcome, Dr. Valerian, for the first session.
Thank you very much, Tony. Good afternoon, everyone, and Happy New Year. Tony, think I can be able to share my screen?
Yes, you are able to share.
All right, so confirm if my slides are visible.
Yes, Dr. Mwenda, they are visible. You can proceed.
Right. Okay, so again, thank you very much for this chance and this opportunity to share on this topic, again, in this occasion of the National Cervical Cancer Awareness Month 2026, appreciating the leadership by the ministry on, creating awareness and continually really creating demand around the various services during this particular month. And also appreciating this platform. I think we've used this platform year in, year out, and it's really enables us to reach many healthcare workers and advocates and other stakeholders in the cervical cancer control space across the Republic. So I'll be giving you a very short talk on HPV pathogenesis and touch briefly on vaccination and how the pathogenesis links to vaccination, and of course other evidence-based interventions for reducing the burden of cervical cancer. Okay, so that's outline on my talk. I'll look at the overview of this virus, risk factors for acquiring HPV, conditions associated with HPV or the diseases that HPV as a virus causes. Then look at the natural history of human papillomavirus or HPV, and link that to the interventions that we use to reduce burden for cervical cancer, and then see what we can pick as the key messages from the talk. So, overview of the human papillomavirus, HPV. So, that's the image you see on the right side of the screen there. That's actually an electron micrograph of the virus itself. It looks, beautiful, like cauliflower. That's the description that, it's given. But it's a small non-enveloped double-stranded DNA virus. For those of us who, are versed with the biochemistry and the various classifications of viruses, it has a preponderance of invading squamous epithelium, and that's how it ends up causing the diseases that we know it causes in parts of the body that have this particular type of epithelium. It's a very ubiquitous virus, really, that is able to exist within various environments, and also hence tends to be transmitted pretty more easily in comparison with other viruses in its group. There are very many, described or discovered types of HPV. Some are pathogenic or they cause disease. Many don't cause disease. As you can see there, last time I checked, end of 2023, there were more than 200 types. But really, very few types cause disease, and these are the ones that are relevant to us in public health. So some interesting facts here about HPV. One, HPV is the most common viral infection of the reproductive tract. So, there are many other infective processes in the reproductive tract, but HPV is by far the commonest viral infection in that part of the body. So HPV is not a risk factor for cervical cancer. HPV is the cause for cervical cancer. And I do believe, most of us understand the difference between risk factors and causes. And so HPV has attained the threshold to be regarded as a cause for cervical cancer for majority of the cases of cervical cancer, up to 99% of the burden of cervical cancer across the world. So interestingly, the way this virus works is slightly similar to the way the HIV virus works. And, we know of so many other similarities between these two viruses. So it integrates itself with the host DNA, and this way it's able to escape the immune system. And through this, then it's able to persist. And that's the issue of persistence. Through evading the immune system is really the pathogenic mechanism through which HPV causes cervical cancer, and also the other cancer types and other conditions that it causes. So many people acquire this virus in their late teens and early 20s, but fortunately, majority are able to clear the virus by around, in their late 20s, maybe by age 30. And then after the infection, it takes as long as 10 years or more for progression to what we call dysplasia, or cellular changes that now can progress to cervical cancer and other cancers. So as I mentioned, this virus has a symbiotic relationship with HIV. We do know that women living with HIV have up to 6 times higher risk of not just acquiring the virus, but also progressing to dysplasia and cervical cancer. And also people with HPV, harboring HPV, also have up to 2 to 3 times higher risk of acquiring HIV. So these two viruses really behave in a very symbiotic relationship. So what are the risk factors for HPV acquisition? And notice that I'm talking about risk factors for HPV acquisition and not risk factors for cervical cancer, right? Because these factors that are listed here are really the risk factors for you acquiring the virus. And as we've seen, HPV is a cause for cervical cancer, majority of the cervical cancer cases. So these risk factors include, usually because it's a sexually transmitted infection, it's all of them are related to one way or another to sexual behavior. So early sexual debut, number of sexual partners, frequency and type of sexual contact. And as you will see, this virus causes other cancers in other parts of the body. And this is related to this. Partner sexual histories and also infection with HIV. So again, similarities here with HIV and also other sexually transmitted illnesses. So this graphic here, for those of us who have gone through the global strategy for elimination of cervical cancer, I think you've seen this graphic there, or many other places, is a graphic that we like using a lot when discussing cervical cancer because it shows us, the natural history of HPV infection and its progression to cervical cancer, at the time it takes for all the steps within that natural history to occur, and gives evidence to all the interventions that we deploy to reduce cervical cancer burden in our population. So as you can see there, infection really peaking, starting rising rapidly from the mid to late teens and to the 20s. And that's the reason why we deploy the vaccine before the age of 15. Many people ask, why are we targeting young girls? That's the reason, is because we want to get, so the vaccine works by preventing infection. We want to get these girls before their sexual debut, as you can see when the infection peaks or starts rising and peaks. And then as you can see, the darker curve there. In towards the late 20s and the 30s, then prevalence of infection itself falls because majority of people are able to clear the virus. But in a subset of people, it persists, and that persistence is what now leads to the long-term changes, the cellular changes that we call dysplasia that you see be described in various terms. And so that's the reason why we deploy screening from that point. So we usually say screening from age of 25, but if you're using HPV testing as a screening modality, we deploy it from the age of 30 years. And as you can see, 15 years since the acquisition of the virus, then 15 years later or thereabouts, that's when we start seeing now a progression to cervical cancer. So that's the reason why we use those particular age cutoffs to deploy the various interventions for reducing the cervical cancer burden. So HPV and cervical cancer, we essentially, cervical cancers worldwide are caused by persistent infection with one of the 13 carcinogenic human papillomavirus genotypes. I mentioned that there are so many HPV types, but not so many that cause disease, and also even a less number that cause cancers. And as you can see there, they are listed here, what you call the high-risk HPV types, 16 and 18 being the main ones, but the others also belonging to the other class of the high-risk HPV types. So as we deploy HPV testing as a modality of screening, basically we are aiming to detect these high-risk HPV types so that we can offer treatment to those women. I did mention that HPV as a virus causes other diseases, not just cervical cancer. So all the modalities we deploy, whether vaccination, whether screening, they have wider benefits in the population. And as you can see here, other lesions of the genital tract, including cancers of the cervix, cancer of the anus, penile cancer, vaginal cancer, vulval cancer, and also cancer in the oropharyngeal tract. But also some other types cause other, diseases that's also seriously debilitating. 6 and 11 types, those ones cause anogenital warts, which I think as clinicians, if we encounter them, we know how difficult these are to manage. And also a serious condition, quite rare but very serious, called recurrent respiratory papillomatosis. So, papilla being forming in the respiratory system. And then there's also what we call non-mucosal or cutaneous infections with HPV, where we have warts in other surfaces of the body, including plantar warts, palmar warts, and other skin warts. So basically, where we have a squamous epithelium, we tend to have infections from various types of HPV. So let me try to link that now with the HPV vaccine, and there's a subsequent talk about this in detail. But some of the opponents against HPV vaccination tend to say that, it has been done so rapidly. The vaccines have just come out of nowhere, and we are supposed to give them to your girls. But that's actually not true. It has taken more than 30, 40 years actually to come up with HPV vaccines that we have now. As you can see there, goes back all the way to the 1970s, really. And then we had the first approved HPV vaccines entering the market around 2006, 2007. So it has been a lengthy period of research across the world, really, to understand the pathogenic mechanism that I've just described to you, and then seeing how we can be able to exploit the fact that now we know that it's an infectious agent that causes these cancers and these diseases, exploiting how we can be able to deploy various modalities, including vaccines against it. So it has been a lengthy process to have the tools that we have at our disposal for reducing the burden of cervical cancer. So another question that is common among the, especially in the healthcare workers, but also in the population as people are becoming more exposed to information, is what exactly is in those vaccines. One of the worries that people keep expressing is that these vaccines are contaminated with other things, and then they'll be deployed to young girls. So what exactly is in the HPV vaccines? And some other people say that they are carrying live viruses. And so, yes, we do know there are some vaccines that have live organisms, but I want to tell you today that the HPV vaccine is not one of them. What the HPV vaccine contains is what is called viral-like peptides. And these are fragments, that are meant to mimic the structure or some of the components of the structure of the virus so that they can be able to trigger an immune response in the body. So these are called viral-like peptides. So all the HPV vaccines currently in the market contain viral-like peptides against high-risk HPV. We have three different groups or classification of the vaccines available at the moment. One of them is what is called the bivalent vaccines. So bi means they target two types, and these are type 16 and 18, which are really they cause the majority of the cervical cancer cases, especially, I think up to 70%. Then we have what we call the quadrivalent vaccine. So the quadrivalent vaccine, as the name suggests, has 4 or targets 4 of the HPV types. That's type 16 and 18, and also type 6 and 11 that, as we've seen before, associated with anogenital warts. Then we have and that's a vaccine that we are currently deploying in the national program in the country. Then we have what we call the non-valent vaccine that has, targets 9 types. So it targets the 4 types, like the quadrivalent, and then it also includes these other high-risk types, that 1, 33, 45, 52, and 59. So those are the 3 classes, really, or types of HPV vaccines that we have across the world. And all the brand names you hear, whether Gardasil, Cervarix, Sicolin, each one of them belongs to, falls under one of these 3 categories. So the key takeaways from this short talk is that HPV is the commonest viral infection of the reproductive tract. HPV is the cause of nearly all cervical cancers, and when I say nearly all, it's actually up to 99 point something. So it's really a cause of majority of the cervical cancer cases. Then HPV causes other cancers and non-cancerous conditions, which are also important. As we've seen, it causes cancers in the anogenital system in both men and women, and also in other systems, again, for both genders. The most effective and the most cost-effective preventive strategy against HPV is HPV vaccination. It's the easiest modality to deploy at the population level. And I think we've been seeing our majority of countries across the world, okay, not majority, but a number of countries across the world are reporting success by just maximizing on the HPV vaccination programs. And a number of countries actually reporting no cervical cancer cases, not even one, in the cohorts that received the HPV vaccine early on. Countries like Denmark, countries like Australia. And I think all these stories then and all these reports go forth to strengthen the argument that vaccination really is the core strategy for reducing the cervical cancer burden. And of course, HPV vaccines are safe and they offer lifelong protection. I think I'll stop there and I'll be happy to respond to questions later on. Thank you very much, and back to you, Tony.
Thank you so much, Dr. Mwenda, for really delving into this scientific aspect of the topic. Dr. Mwenda is very passionate on this, and he comes in handy with a lot of scientific expertise and knowledge. So we really appreciate your insights. And I believe that the members on this webinar have been able to tap into this knowledge, and going forward, we'll be able to even look at some of the questions that will be asked by the participants. So thank you once again, Dr. Mwenda. I want us to transition to the next presenter, and that will be Christine Miano. So Christine is Christine works at the National Vaccines and Immunization Program, and Christine is a program officer who heads the social behavior change communication section of NVIP, and she is a national strategist who aims to strengthen vaccine uptake, and also with a particular focus on HPV vaccine as the cornerstone of cervical cancer prevention. So with a lot of expertise in this, and also looking at the evidence-based communication, stakeholder engagement, and community mobilization, Christine has been able to spearhead the national HPV vaccines campaigns, and has been able to address behaviors and behavior barriers, and also beyond vaccine confidence among adolescents, caregivers, and also healthcare workers. So she has played a vital role in designing and implementing outreach strategies that have been able to ensure that girls across Kenya, and even those in hard-to-reach areas, have been able to get access to the HPV vaccine. So she comes in handy with experience in coordinating multi-sector advocacy, refining training materials, and also translating insights into actionable policy. So welcome, Christine, for the next presentation. You can go ahead and share your screen. And we continue to urge members to utilize the Q&A section in the chat box, so that we can be able to respond to these questions after the last presentation. Welcome, Christine.
Thank you very much, Tony, and good afternoon, everyone. It's a privilege to be here talking about HPV vaccine, and thank you for taking time to attend. So let me know if I am sharing my screen.
Yes, Christine, you are sharing your screen. Maybe you can just put it on presentation mode.
Okay, let me work on it again. It seems to be disappearing on my end. So I will be translating from what Dr. Valeria has talked about to policy and practice on what we do on HPV vaccine in the program. So just a brief overview of the program in our country is just to tell you that we have 47 counties and one national government. So as vaccines program, we are under the national government to ensure that there's policy implementation and of course, standardization and supply of vaccines. Our counties are in charge of the implementation of the vaccination program. Therefore, we work closely with all the 47 counties by ensuring that they get the right policies and that they have the right equipments and tools to be able to implement. We are currently working with a projected population of 57 million. But what I would like to emphasize most is on the HPV vaccine, where our target population in the country is 814,000 girls every year targeted for HPV vaccination. That is for a single age cohort of 10-year-old girls. And then in form of our supplies of vaccines and vaccine-related supplies like the syringes, the safety boxes, and the reporting tools, we have a central vaccine store where we receive all the vaccines from the manufacturer, and these vaccines are distributed to the 9 regional vaccine stores. And then from the regional vaccine stores, we have the counties taking the vaccines to all the sub-counties, the 320 sub-counties. So supplies from the central vaccine store is supported by the national program, and then supplies a collection of vaccines from the regional vaccine stores to the sub-counties and to the health facilities. This is the responsibility of the county government. Therefore, we work closely with them to ensure that all the health facilities have enough supplies to be able to vaccinate all the girls. Currently, we are at 8,600 health facilities, and we work closely with the community to ensure that there's a lot of surveillance that is going on, and reporting and documentation of the same. I want to reiterate that vaccine is proven to be cost effective. This is what my former presenter has said. It's very effective. It's a good tool for preventing the preventable diseases. And in our country, we have prioritized vaccination as early protection by ensuring that vaccines are safe and efficacious and also relevant according to the needs of the country. So, National Vaccines and Immunization Program was launched in 1980. And since then, we have been successful in eliminating diseases like diphtheria, nearly eliminating pertussis, and also control of measles, polio, and other life-threatening diseases. And you can attest that we have minimal outbreaks, and we have nearly not seen some of the diseases that we vaccinate our children. This is because of because of the success of immunization. Now, HPV vaccine was introduced in our country in 2019, and I would like to confidently say that HPV vaccine is into the routine immunization schedule. So this is part of the immunization that is given in our schedule, and we targeting 10-year-old girls with only a single dose of the vaccine. No, the vaccine now targets the primary population of 10-year-old girls. This is when we want to get them before they get the exposure of the virus. And this age was primarily discussed and agreed upon by the Ministry of Health to ensure that our 10-year-old girls would be best fit to get this vaccine as they have no exposure to the virus. We also provide an opportunity for the 11 to 14-year-old girls who may not have been vaccinated with HPV vaccine to get a vaccination. So if there is a girl 10 to 14 years, they are eligible for vaccination. So therefore, we do not want to miss any opportunity for them. The vaccine comes as a single dose schedule. I know initially in the since post-COVID, we expanded the since introduction, we've been giving 2 doses, but following recommendations from our advisory and regulatory bodies, 1 single dose is as effective. And as at November 2025, we switched from a 2-dose schedule to a 1-dose schedule. So girls are eligible for just 1 dose for maximum protection. Now, this vaccine comes as a single dose vial, and according to the image that you see there, that 1 vial is for 1 girl, and it comes as a 0.5 ml, at the right temperature. So this we ensure that for the potency of the vaccine, we store it at the right temperature, right from the central vaccine store to the health facility up to the time it arrives at the arm of the girl. We give it as an intramuscular injection, and we also have emphasis on those girls that have immunocompromised or those that are HIV infected to continue getting the 3-dose schedule. So what I would say is that since introduction of HPV vaccine in 2019, more than 3 million girls have received at least 1 dose of the HPV vaccine. And out of these 3 million girls, I would say that about 2.5 million girls completed the schedule. Now, because we have switched to a single dose schedule, we are hopeful that we will get 90% vaccination of the girls to be able to near elimination strategy of eliminating cervical cancer in the country. For those concerned about the safety of the vaccine, it is safe, it is effective in preventing cervical cancer disease. So as a program, we have strategies that we deploy to ensure that every girl is every girl is reached and does not miss an opportunity. Now, the vaccine is given in health facilities, public facilities, private facilities, faith-based facilities. They have access to the vaccines. Then we also do whole site orientation to all service providers. Now that the vaccines are available in health facilities, vaccinators and non-vaccinating health workers are provided that orientation to ensure that they give correct information to the caregivers and to the public, and ensure that no girl is missed when they visit the health facility for any other service, including vaccination. Then we also do screening of 10-year-old girls as they visit health services so that we don't encounter a missed opportunity. For us, every girl matters in ensuring that she gets vaccinated. Now, other than the health facility strategy, we also do outreaches, and our outreaches are conducted in the community and in the schools. And this we work closely with the community leaders, the community health promoters, and the teachers, so that we have a good linkage, we have a good collaboration in ensuring that we reach girls in school, we reach girls out of school, and the identifying of appropriate strategies to get them. Now, I would like to emphasize on the areas of interaction with girls for these HPV vaccines. Health facility vaccination during immunization sessions. We encourage that parents walk in with their girls for vaccination. We also encourage that teachers or schools that are near a linking health facility to have the girls brought to the health facility for vaccination. Then community outreaches, like I said, where we target school vaccinations and community vaccination, including the hard-to-reach populations, both in the rural and in the urban areas. Then school outreaches, where we integrate with other health programs, and active screening. We know that these girls have other special needs, like the non-communicable diseases. So when they are coming for their special clinics, we work closely with the health workers in those special clinics to ensure that they check for eligibility of HPV vaccine for the girl that is visiting the clinic. And of course, when we are conducting other catch-up activities or intensifications, like during campaigns on measles, rubella 2, or any other catch-up that we are conducting, we ensure that HPV vaccine is one of the vaccines that is offered during the catch-ups. So those are the areas of interactions and many more that we ensure that we don't miss our girls on. Now, in terms of data and ensuring that we capture our data and all girls are entered for accountability, we have two documents that we use. One is the health facility register, and this register is based at the health facility, which is used by the healthcare worker during vaccination at the health facility. This document is a basis for tracking the individual immunization status, and through this is what informs the country on the number of girls that have been vaccinated from the health facility all the way to the national level. It also serves as a record to show that the girl has been vaccinated. We have another tool that is the school register for HPV vaccine. We work closely with the Ministry of Education, and when health workers visit schools for outreaches, we ensure that this data is not lost by having this document staying with the school health teacher. So the school health teacher is responsible for registering eligible girls, girls who have turned the age of 10, girls who have who are at the right age but have not been vaccinated. So the teacher is in charge of ensuring that this data is entered into the book and updates it, then liaises with the health facility in charge to plan for immunization services, and even for missed girls, how they would be reached following a missed opportunity in the school outreaches. Do they have them taken to the hospital for vaccination, or can we schedule another outreach in the school to capture those girls that have been missed? Now, once a girl has been vaccinated, she is given a vaccination card as proof of the vaccine that she has been given. So this card is filled by the health worker after the girl has been vaccinated, and it serves as proof that she has received a vaccine and also avoids any duplication should a health worker come into contact with this girl in the next visit. Now we have roles as health workers, and I am happy because quite a good number of us have attended this meeting. And I know that we are going to drum support for ensuring that HPV vaccination, being the primary prevention, is of course being given to our girls, and that we are going to drum support for HPV vaccination. Now, this is our role. It would be important for us to collaborate with the community leaders. Remember where you sleep, where you go in the evening from work, where you stay, that is your community. And you are a leader that is trusted, and people come to you for information. So ensure that you collaborate with the community leaders, the public, and the community health promoters to identify the girls that are eligible. Either refer them for vaccination or talk to their caregivers to ensure that they get vaccinated. Our role is to educate parents, teachers, and caregivers on the vaccine safety and the benefit of the vaccine, because we want to build confidence and trust. And what we have realized with HPV vaccine is that the public is so much concerned about the safety. So building confidence and trust with the public is very important for us as health workers. Then safely delivering and documenting vaccines across schools and facilities and outreaches. So that is a key role for us. For those in the vaccination sessions or rooms, ensure that girls are all reached with the vaccination, and follow up for those that are out of school and those that are in vulnerable populations. For example, we have girls that are eligible for vaccination, and probably they are in special schools, probably they are in the nomadic population, Probably they are in the street families. How do we follow up to ensure that there is equity, that no girl is left behind? And how do we ensure that we address concerns that the public may have, that this parent may have about the vaccine and vaccinating the daughter? So that is one of some of the roles that we have. And we also have roles for teachers. Remember, HPV vaccine also is given in school. So what is the role of the teacher in ensuring that there is high uptake of HPV vaccine in the school? Mobilize girls. Ensure they get accurate information about the vaccine so that they are informed, so that they can understand what they are getting and why they are getting it and why it is important for them to get it. And then coordinate with health teams during school vaccination activities so that you bring on board the eligible girls so that we don't interrupt the class sessions, so that we get the smooth flow of vaccination in good time and conduct health education sessions before the vaccination actually happens. Then the teacher is also responsible for addressing myths and misinformation among the learners and among the parents. We have had good collaboration with the teachers. We've been conducting sensitization with the teachers, so they know a lot about HPV vaccine and therefore good advocates for addressing myths and misinformation. And of course, updating the school health register, like I had said earlier. Now, having ensured that we have vaccines and we have the right target population, how do we ensure that the community is now informed? How do we communicate to the community so that they have informed choices? Now, what we do is to ensure that we have appropriate communication skills. And this is impacted to us as health workers through trainings, capacity buildings, and sensitization meetings. This is done to provide skills to our healthcare providers when they are interacting with the caregivers and the community as well. And we also do use of culturally acceptable channels. We have done needs assessment to know which channel works best for each audience. So each audience is going to get targeted messages that is right and acceptable for them and also culturally acceptable for them. So we develop packages and key messages that are acceptable for each of our target audience. We provide factual information that is consistent, that is able to address the myths and misinformation, and this we do through various channels. For example, posters, radios, and even interactive sessions. Then after that, we get human interest stories. Now, health workers are role models. They are advocates. Human interest stories are very important for the public. This contributes to confidence and trust. For example, I have a daughter who is 10, 11, or 12 years old. I have vaccinated my daughter with HPV vaccine. I no longer have to worry about her future because she is protected. Such kind of human interest stories that the community can relate with is very important to increase immunization uptake. And also not forgetting to use our social media handles because they are the key thing nowadays for us. We have various channels that we use. Interpersonal communication, very key because this is a one-on-one interaction where you can address concerns of the public on the many myths and misinformation they may have. Community engagement is also key through the leaders to build trust and have a collective action plan. And of course, we do a lot of stakeholder engagement at the national, at the county, at the sub-county level, where we bring in all our partners, our religious leaders, the professional bodies, all our stakeholders to ensure that we are speaking the same voice and amplify the health message of HPV vaccine to everyone for support. We also have media channels that we use and the social media platforms that are now taking the front stage in ensuring that messages are reaching the public in a very short time for a very wide public. And at the same time, social media platforms are allowing us to have a very good interaction where one can ask a question and get feedback immediately. So thank you, members, for this. I call upon your support for HPV vaccination. It is a primary prevention. Let us shout, let us tell people that HPV vaccine is key to protecting the dreams of our girls. Back to you, Chair.
Thank you so much, Christine, for your elaborate presentation. Thank you, Christine, for your elaborate presentation on HPV vaccination and even highlighting on from a scientific point of view and also a programmatic point of view, looking at how we package the information on HPV vaccination uptake, because this is aimed at ensuring that we really demystify the myths and misconceptions around HPV vaccination. So remember that, as has been said by Christine, HPV vaccination is actually the primary method that we use to ensure that we prevent cervical cancer. And we've been able to get to know the current updates with regards to this vaccine, and even looking at what are we doing from the counties as healthcare workers in order to ensure that we increase uptake of HPV vaccine, just in alignment to WHO's 90, 70, 90 elimination targets for cervical cancer. So thank you once again, Christine. And at this point, I want to go to the next and the last presenter. And we'll have a presentation from Dr. Joan Paula Bor. So it's my honor to introduce Dr. Bor, who is the head of the National Cancer Control Program at the Ministry of Health. And Dr. Bor has really been instrumental in ensuring that she leads Kenya's cervical cancer elimination. So she will take us through the National Cervical Cancer Elimination Action Plan, and she'll be able to ensure that we are able to really know what the program and the ministry is doing towards eliminating cervical cancer. So welcome, Dr. Bor, for the next presentation.
Thank you, Tony. Good afternoon, everybody, and I hope you're doing well. Happy New Year. The year is still young, and I'm honored to join you today to make this presentation, which I hope will not take a very long time. And it is on Kenya's path towards cervical cancer elimination. This is how I have titled it, because I want to set the scene for the National Cervical Cancer Elimination Action Plan, which will be launched later this week. I do not want to preempt, so that is why I'm not really what I want to do is not really to unpack the action plan. It will be launched on Thursday. So I just want to give you a sneak preview, just to explain to you a bit of the background, and then we'll continue to unpack it together and as we disseminate it. So as you have heard, I head the National Cancer Control Program. I thought I will also mention that the National Cancer Control Program is the Ministry of Health technical focal point that coordinates the implementation of cancer control in Kenya in line with the National Cancer Control Strategy, focusing strongly on the health system. Our core roles as NCCP is policy guidelines and standards, capacity building, and offering technical support to counties and other stakeholders. And how do we do this? We achieve this through technical working groups, national technical working groups that serve for coordination of partnerships and collaborations. And this webinar is even courtesy of one of the national technical working groups, which coordinates cervical cancer elimination activities. And then the other thing that we do is monitoring and evaluation and surveillance. That is tracking our progress to inform policy and planning and how we can improve our health system response to cancer. So having said that, in my presentation, what I intend to cover is why does cervical cancer elimination matter now? I think after the presentations by Dr. Valerian and Christine, it is evident. And then I will also go through what are the global commitments and what is our Kenyan response. And then how was this action plan developed? What are the vision, goals, and guiding principle? And are there key operational areas? I'll tell you. And then how do we enable this plan? How do we make it a reality? And lastly, what is next? So why does it matter? Why does cervical cancer elimination matter right now? And I'll say cervical cancer is the leading cause of preventable cancer deaths among women. It is a leading, it's not the leading globally, but in many low and middle income countries, it is the leading cancer cause of cancer deaths. There are a lot of inequities which drive disproportionate burden in low and middle income countries. Then also there are interventions that have been proven and they are cost effective across the continuum of care, as you have heard. And then there is the WHO call for elimination and the launch of the strategy in 2020, which has created unprecedented global momentum. Now we are seeing many countries are having formal national plans and strategies and even dedicated funds for cervical cancer elimination. I can mention Australia, Indonesia, Malaysia, Rwanda. Rwanda are even aiming to, they are on a mission to eliminate cervical cancer by 2027. And then lastly, we have Nigeria. There are other countries as well. I just sampled a few. So in Kenya, what is the story? The story for us here in Kenya is that cervical cancer is number one leading cause of cancer deaths among women and even overall. And then we lose 10 women every single day to cancer. So this is a tragedy because this is entirely preventable. And I believe we have been explained to why. So Kenya is positioned to align our national action with the global movement. And by developing a comprehensive national strategy, we can save thousands of lives and become a regional leader in cervical cancer prevention and treatment. Globally, there is this strategy for elimination with the goals, 90-70-90 goals. And this strategy was launched by WHO in 2020. And it requires countries to attain these set targets by 2030 to put them on the path to elimination. So we are looking at 90% of girls being vaccinated by age 15, 70% of women being screened at least twice in a lifetime using a high performance test, and 90% of women identified with cervical disease receiving treatment, whether it is for precancer or for invasive cancer. One thing that is very clear in the global strategy for elimination is that health system strengthening is key. And these are particular drivers that will be needed for elimination. Investing in primary health care, strengthening domestic resource mobilization, improving access to HPTs, and engaging private sector, not just focusing on the public sector. Universal health coverage, leaving no one behind, is key. Innovation and digital technologies for health. Quality, a focus on improving quality in the health system is very important. And lastly, data systems and M&D. So from the global picture there, we also have our Kenyan response, and this action plan aligns with the National Cancer Control Strategy, which we're implementing. We're like smack in the middle of it from 2023 to 2027. And the vision of this strategy is a nation free from the preventable burden of cancer. We have heard that cervical cancer is preventable. So it's one of the main cancers that we are focusing on through these 5 pillars that go along the cancer continuum of care, from prevention and early detection, cancer imaging, pathology and lab medicine, treatment, palliative care and survivorship, advocacy, partnership, and coordination in financing, which is pillar 4. It's critical. And lastly, the 5th pillar, which is strategic information registration and research. So the action plan aligns with each of these 5 pillars. Now, you may be wondering, is Kenya on a path to elimination currently? And the answer is an unfortunate no. When we compare where we are, and this is data for 2023, when it comes to vaccination, we were at 54%. I think we are doing better in 2024. We are in the 60 something. And then for screening, we were targeting 70%. Using a high precision test, that's the catch. We were able only to do 6% using HPV test. Overall, using other methods, including visual inspection, we are at 42%. And then 90% of treatment, we have made remarkable progress because we are at 43%, but you see there is still definitely a gap and we are not on the path to elimination. How did we develop this action plan? Through a country-led, evidence-informed, and multi-stakeholder process, which started in 2024. The discussion started then, and the prioritization, and we had several stakeholder engagements. We were working closely with Health Systems Insight, where Dr. Mwenda was leading this activity, as well as with Chai Clinton Health Access Initiative and other partners and stakeholders. So we had in March a co-creation workshop. In April, we were generating evidence, on the health impact, the feasibility and all. Then we proceeded to do a drafting workshop in May and a second drafting workshop in September, where we focused on resource mobilization, costing, and the advocacy plan. Whereas in May, the focus was really on the strategic model. Then in September, we had external review. We had very good external reviewers who worked with us from the international organizations like WHO, International Agency for Research in Cancer, and so on. And then we had a validation workshop in October. We had internal and external validation. And then finally, the document was ready by early November, and we subjected it now to review at MOH and finalization and endorsement by our MOH leadership. I'm happy to tell you that the document is endorsed at the highest level. The CS actually is the one who has signed it, but as well as the Principal Secretary for Medical Services and the Director General for Health. So we are looking to launch it, as I said, the day after tomorrow. The vision of the action plan, this is as much as I can tell you, is a Kenya free from the burden of cervical cancer. And the mission is to provide timely, equitable access to evidence-based, cost-effective, and quality HPV vaccination, cervical cancer screening, diagnosis, treatment, palliative care, and survivorship. And the goal is to achieve the 90-70-90 targets by 2030. The core values, we have integration, we have collaboration, sustainability, governance, advocacy and education, capacity building, and coordination. So those are the core values, and you can see why when we will continue unpacking, it will be more evident why these are the core values. The action plan has several key operational areas, which we are calling the pillars. and they are aligned with the 90-70-90 targets. So there is HPV vaccination, there is screening and treatment, and there is diagnosis and treatment for invasive cancer. So that is those are the three pillars. We will read more about the strategic, the operational objectives. Each of these has operational objectives and specific activities. How will this plan be enabled? The plan clearly outlines the resource requirements that are needed. It outlines the resource mobilization strategies, for financing it, and then how do we manage the resources, the few resources that are available. Then the plan also has a meal plan, monitoring, evaluation, accountability, and learning framework with priority indicators. I must say these are aligned with the National Cancer Control Strategy. And then also implementation framework. This one, when you look at the implementation framework, you will see that partnerships are core. And then also we have coordination and we have shared responsibility coming through when we look at that implementation framework. So as I said, today was not the day to really unpack it, but just to sensitize you, to orient you, and to leave you, ready to receive this action plan when it will be launched. It will be launched on 15th January in Nairobi, and there will be a link for virtual attendance, which we will liaise with KNH to provide for you. So with that way to the end, I hope this leaves you, prepared and ready to receive the action plan when it will be launched. Thank you so much, and back to you, Tony.
Yeah, thank you so much, Dr. Bor, for taking us through the insights on the cervical cancer elimination action plan. And I really want to appreciate and thank you for sharing with us that preview. And I believe the members on call are really looking forward towards the launch and also dissemination so that we can be able to even unpack the action plan itself. So we are really glad and we are honored to get this information in as much as it's just a tip of the iceberg, but leaves us very much ready and eager to get to know what's contained in that document. So I think we are done with the presentations. Thank you so much for the questions that are coming in. And I want us to now tackle the questions that have been coming to the chat box. I see we have a couple of them. And maybe for the first question, I will direct it to Dr. Valerian Mwenda, because this is a question that I have seen has been recurring quite often. And it's based on vaccination. So there's this question about the vaccination of boys, and maybe we can combine it with the vaccination for older women. So maybe we want to get the insights from a scientific point of view, whether there is really value to vaccinate boys and also older women. Dr. Valerian, kindly.
Thank you, Tony. Great question. And the answer is yes. There is evidence that vaccinating boys and even vaccinating older women is efficacious at the population level. So the reason why Kenya and many other countries across the world, especially LMICs, have focused on girls first is, looking at the disease burden, really, cervical cancer being on top there, if you compare with the other diseases that I showed you. So, there's that, initial, primary focus really to ensure that we're reducing cervical cancer itself, the burden, meaning reducing the chance of these girls getting cervical cancer in future. But also it's because of logistic and financing constraints, really. Otherwise, the country would have launched a gender-neutral program. So for now, the focus is on girls 10 to 14 years, or by the time they're hitting 15 years of age, hoping that maybe in future, the country will have more resources within the health system to be able to open it up to have boys and maybe older women as well.
Yeah, thank you so much, Dr. Mwenda, for that. The second question is to Christine, and I want to handle the question on are the efforts towards health education, like prevention of early sexual debut, incorporated into maybe the messaging that we give to our school health department. So are we really having efforts towards ensuring that we do health education, especially on prevention of sexual debut? Christine, kindly.
Thank you, Tony, and thank you for the question. It's a very wonderful topic for us to address. I would like to say yes, National Vaccines and Immunization Program does not work in ISO. We work closely with other Ministry of Health programs. For example, we work closely with the Cancer Control Program, Reproductive Health Program, Health Promotion Program. We also work with the Ministry of Education. And each program has a mandate on what they do in targeting this same girl. So we work closely to ensure that this adolescent girl that is targeted in terms of health, what relevant health information do they require apart from vaccination aspect of it? So sexual health is also addressed by our sister programs. And remember when I was doing my presentation, I said that we collaborate closely with our stakeholders, with the ministry, with all our partners to ensure that even information that is required reaches the girl before vaccination. So this is also addressed to ensure that they should be able to abstain, because that is the desire of every parent, of every person, that they should ensure that they take care of their sexual health and to ensure that they engage at the right time so that they don't get the HPV infection. Back to you, Chair.
Yeah, thank you so much, Christine. So I want Dr. Bob to handle the next question. And even looking at the cervical cancer elimination action plan that is due to be launched, there is a question pertaining to the high precision tests. The question reads, which is the high precision test, and what's the availability at every county and facility levels, and what is the role of screening tests we use, that is considering the via villi method of cervical cancer screening. Dr. Bor. Dr. Bor, did you get my question? Okay, maybe as Dr. Bor prepares to respond, I want Dr. Mwenda to handle the question by Collins. So there are two questions by Collins. So the first is early sexual debut an independent risk factor to acquisition of HPV infections, or does it also depend upon multiple partners? That is, for example, if early sexual debut is on the same person for life, does that change the risk of acquiring infection? And then the second question is, do you have any local data on the incidence of penile cancers? And if so, any plans to deploy the vaccines among boys and young men? Probably the second aspect of question might have actually been responded by Christine. So maybe you can go with the first question.
So on the first question, the answer is yes. Early sexual debut is an independent risk factor for acquisition of HPV, and this is related to the biology of the maturation of the squamous, the mucous membranes of the squamous cell epithelium that I mentioned is closely related to acquisition of HPV. So there's a lot of science that has been done around the interaction between the virus and the squamous epithelium, and studies show that the mature epithelium in the cervix really is more prone to being colonized by HPV. So that early sexual debut in itself is an independent risk factor. The second question is about penile cancer. So penile cancer is quite rare, especially among immunocompetent men. And even among immunocompromised men is not really the topmost, like HIV-related malignancy, really, even in the country. Many other cancers on top there. So looking at the disease burden alone, it doesn't really rank that high for countries when they're making decisions on whether to start a gender-neutral vaccine. Actually, one of the reasons why gender-neutral vaccine is proposed for two reasons. One is for the oropharyngeal cancers that are actually they are more prevalent among the two genders, not even among men alone, but I think higher among men. So they are more prevalent than penile cancers. But number two is something called a herd immunity. So by vaccinating boys, you actually also protect girls indirectly through the concept of herd immunity. So really the reasons why many countries start with girls, or at the moment are focusing on girls, has nothing to do so much on epidemiology or the efficacy of vaccines among the other gender, is really because of constraints. Because a number of these countries, they have not even been able to introduce and scale among girls to start with before they expand to boys. And majority of countries, even the Western countries, they started with girls first, expanded and scaled that, and then moved on to a gender-neutral regime.
Thank you so much, Dr. Mwenda, for that. A question about vaccination to Christine. So the question reads, how are we currently capturing data on additional doses for girls with suppressed immunity? Any good practices to share? For example, linkage to the CCC, that is the CCC clinics and caregivers. So maybe, Christine, you can respond to that.
Thank you for that good question. Data for girls that are immune compromised, we have our reporting tools that we use for ensuring that we capture data for girls that have been received vaccination. What I would like to say is that for the girls that are immune compromised or with HIV positive, they are eligible for 3 doses of the vaccine. And therefore, what we do in our data as we are vaccinating, one is to ensure that this girl is gotten in the clinical areas and vaccination is offered. And then the vaccination card is indicated on the vaccine, the dose that is given, and the next visit for this girl for the next dose that is scheduled until they get their 3 doses. So we have this data in the HPV vaccination card, but we also ensure that we capture the data on our reporting tools to ensure that we get the number of girls that have received this vaccination. We have good practices, of course, that our own counties as implementers could showcase. Like I said, screening for eligible girls at the clinic areas, even when visiting the outpatient, is one of the practice that we have ensured that has taken place in all the 47 counties. We have ensured that even the non-vaccinating health workers have the relevant updated information to ensure that they are equipped to share that information with everyone approaching them. So these are just some of the good practices that we have. We ensure that counties are reaching their girls and ensuring that they come up with ways and channels of communication to reaching even the remotest health facility to get the health workers reaching this information. Most of the practices we learn from the counties, and we work closely to ensure that we have exchange of programs within counties to see what they can improve or what they can adapt from these counties. Back to you, Chair.
Yeah, thank you so much, Christine. And I really want to comment that quite a number of the questions that are being raised are geared towards HPV vaccination, and that means that this is a pertinent issue that we really need to keep engaging and even building advocacy on. So I really want Christine to look at the next question as well. And I will read the question that Christine, apparently there is still a contrary voice from the religious front with regards to promotion of the HPV vaccine uptake. Just to mention a few of the concerns are safety issues such as infertility, fear of a foreign hidden agenda, amongst others. So do you have in place any other strategies to address this impediment besides sensitization?
Thank you, Tony, and thank you for our participant for this question. Yeah, we have done several studies, social behavior change studies, to see what really is the concern of the public in terms of the HPV vaccine. And what we have discovered is that the public is informed. They are aware of HPV vaccine. What hinders the uptake of HPV vaccine is the mis and disinformation. So how we ensure that we give factual information is by working closely with all our stakeholders. By this, I mean our religious leaders are key, and they are at the forefront of supporting HPV vaccine. We have brought on board and we have regular meetings with the religious leaders. And I remember last year, around October, November, when we were doing the vaccination switch, we got a lot of support from our religious leaders. And they even went to the media stations to talk about eliminating cervical cancer. So, of course, we have a few religious sects that do not believe in alternative medicine and that do not have concrete information on HPV vaccine. So what we do is to try and use those that are near them, those that they have a hearing, those that have influence, to educate them and tell them on the importance of preventing the daughters and the sisters and the mothers from cervical cancer. But what we are seeing is that religious leaders are at the forefront of supporting us. We have had sensitization meetings with them. We have conducted advocacy meetings with them, and we have developed a booklet for all the religious leaders, the Christians, the Muslims, the Hindu, all of them. We have developed a booklet on immunization and other health-related topics that will empower them, give messages when they are giving their sermons. So I will say that religious leaders are supporting HPV vaccine and cervical cancer elimination in the country. Mis and disinformation on the safety, infertility is what we are asking, that you provide factual information, because one lacks factual information, and that is where we have a gap of misinformation. So drum support for the safety of the vaccine. Dr. Valeria has just said the vaccine is safe. I have just confirmed that the vaccine is safe. In fact, what we are doing is to protect the fertility of this girl. because when she's free from cervical cancer, then her fertility is protected. A call to action to all of us: ensure that we give factual information. And that is why we are holding webinars and other channels, to ensure that we give information and we empower you and we give you your roles to ensure that you reach the public and the community and the relatives that you are with in giving correct information. Back to you, Chair.
Thank you so much, Christine, for that elaborate response towards HPV vaccination uptake and also looking at the safety and efficacy issues. So for the last question, I want Dr. Bor to respond, and it's from Grace. It's actually on the action plan. So I will read the question that on the action plan, I noted that you have a meal. The R will have read the MERL, including ongoing research, has been left out. So is there any particular reason, or is it a slight oversight? I believe that she was alluding to the monitoring, evaluation, accountability, and learning aspect of the action plan. Dr. Bor, kindly.
Tony, kindly just clarify. The question is whether what has been left out. I missed that part of what has been left out.
I believe she's alluding to the meal framework.
Yes.
And also incorporating an aspect of ongoing research with matters as cervical cancer elimination.
Oh, okay. She'll forgive me if I don't understand the question very well, but just what I can say is that the National Cancer Control Strategy is accompanied by a comprehensive monitoring, evaluation, accountability, and learning framework. Now, when we have developed this National Cervical Cancer Elimination Action Plan, it also has an implementation framework and also a monitoring, evaluation, accountability, and learning section somewhere at the back. I found the question from Grace on the action plan. I note you have meal. They are to have read it as MAL, including research. Okay, whether research has been left out. I finally understand the question. Research has not been left out in the action plan. Yeah, and you will see when we unveil it that research is still important. It may not be I'm even now trying to open it so that I can confirm that question. Yes. In the National Cancer Control Strategy, what we have is the meal framework, which focuses on the accountability, but it also has pillar 5, which talks about research. So in this case, in the action plan, it's one of the cross-cutting issues. Research is one of the cross-cutting issues that are included in the action, in each section of the action plan. Each result area has its cross-cutting issues like M&D, issues like financing, workforce, governance, community engagement, and so forth. And so each of the pillars has a research area. So research has not been left out. It has been weaved in, and you'll see when you get the action plan. Thank you.
Thank you so much, Dr. Bor, for that response. And looking at the time, I think we are at the top of the hour. And I want to take this opportunity once again to really thank the participants for taking your time and ensuring that you attended this webinar. It was well attended, and we really continue to appreciate the efforts that each one of us is playing with regards to ensuring that we eliminate cervical cancer as per the 1970-90 strategy. So thank you once again for your commitment and even creating awareness. So we look forward to seeing you once again next week and even the subsequent weeks so that we can continue advocating for cervical cancer elimination. So maybe just to wrap up, I want to take this opportunity once again to give a moment to Dr. Bor to officially invite us to the Elimination Action Plan Symposium, and also that is virtually, and also be able to tell us of what is expected probably after the launch. So Dr. Bor, maybe you can tell us a word and give us your blessings, and then you can officially close for us. Thank you so much.
All right. Let us give a hand clap to Tony, who has been our moderator, and he has done a fantastic job, as well as our panelists, my fellow panelists, as well as the technical team at KNH. Nelson and your team there at KNH, we really appreciate you. So, as I have mentioned, the National Cervical Cancer Elimination Action Plan will be launched on 15th February in Nairobi, and you are invited to attend virtually. We will liaise with the technical team at KNH to share with you the link so that you can follow the proceedings. It is a national symposium. It is a 2-day event, and you'll be able to pick up a lot of learning, knowledge sharing, including local and international speakers who will be, bringing to the table new information and even sharing experiences, not just from Kenya, but international, but also even for Kenya, not just from Nairobi, but from all counties. So I want to invite you to attend, and I want to recruit you as a cervical cancer elimination champion. Yes, with the information you have received today, you can do something about it. So if you have not been screened personally, you need to be screened if you are eligible, and if you are a gentleman and you have an audience, I believe, so you can make sure that the people around you, the women around you, get screened. Parents and the guardians of 10-year-old girls, please get the girls vaccinated. And the ones who are even up to 14 years, they can still get the vaccine when they present themselves at the health facility. So be our champions for vaccination, be our champions for screening, be our champions for elimination. We will go this journey together. So upon the launch of the action plan, implementation will begin. So as a stakeholder, also in your role, maybe as a healthcare worker, maybe as an advocate, as health champion, we also have a role to play in the implementation, and we will continue to disseminate it through such forums. And I think we can truly achieve cervical cancer elimination in our country. I'm convinced. So I wish you a good afternoon and blessings. Invite you to join the next webinars as displayed on the screen. Kwaherini, have a good evening, and God bless you.